So, welcome to ENT student for discussion on assessment of patient-based outcomes measures. So, number one is appropriateness. Number two is validity. Number three is reliability. Number four is responsiveness. Number five is precision. Number six is interpretation. And number seven is acceptability. Number eight is feasibility. So, appropriateness, whether it is appropriate or not, you should know. Validity, whether the instrument is valid or not, you should be having in mind. And reliability, you should be keeping in mind about to produce the same results, whether it is producing the same time or same or not. Especially when you take in validity, you have got the face validity, you have got the content validity, you have got the construct validity. Face validity about the function of the instrument, and then content validity, and then content validity is about the domain of the instrument, and construct validity is about the idea of the instrument. And reliability, when you take, so when you have to rely upon a particular instrument, you should keep it in mind about the instrument that produces the results with the same time, same result will be coming or not, you should be keeping in mind. So in reliability also, you should think about the size of the error. If the error size is increasing, you need a higher sample also. Sample size also should be increasing. Next, fourth one is the responsiveness. Responsiveness, as you could see, that whether it is clinically meaningful changes in the patient condition, whether the patient is having some changes in his condition, whether it is responding to treatment or not. And fifth one is the precision. Precision, when you are thinking about the small differences, you are able to see or not. So in this precision only, we have dealt about the true differences in health states. Yes or no, you can be telling, or you can say it like at scale from very satisfied, satisfied, not satisfied, dissatisfied, very dissatisfied. All these things can be there in precision scale. And even this visual analog scale comes under with 10 points in this precision. So now we are going to see about the interpretability, whether it is clinically irrelevant or relevant interpreted, acceptability, whether it can be planned for further future, and feasibility, whether it is feasible or not. So now you can change.
Yes, sir. Precision or sensitivity. The preferred term is precision, as sensitivity has a number of other uses in research. Precision is the ability of the instrument to reflect true differences in the health states. As clinical trials often aim to detect small differences between the patient groups, precision is a desirable capability.
Next, precision is based on sensitivity.
Yes. One of the main influences on the precision of an instrument is the format of the answers. The simplest answers are yes or no, but they do not allow any assessment of difficulty or severity. Most commonly used graded response is Likert scale, such as very satisfied, satisfied, neither satisfied or dissatisfied, dissatisfied, very dissatisfied.
Next,
There is some evidence that using 7 responses categories rather than 5 increases precision. So this is rarely used. The main alternative to Likert scale is a visual analog scale, where patients can mark and point on a line to represent their answers. Though this would appear to offer more precision, comparison studies of the Likert scale and visual analog scale have found no advantage of visual analog scale. In addition, it appears that visual analog scales are less acceptable to many patients who find it difficult to translate their feelings into numbers.
next,
It is important to note that the questions should be worded as to potentially elicit all points along with whichever scale is used. That is, avoiding wording that elicits only yes or no responses. Patients-based outcome measures are generally converted into numerical values for statistical analysis. Most instruments use simple ordinary values, for example 1 to 5 or 7 for a Likert scale, which are capable of less precision. However, the majority of the published reports of health status measures use parametric statistical analysis that is appropriate for interval scales. Uh, Though the interval between 1 and 2, very satisfied and satisfied, may not be same as between 4 and 5, dissatisfied and very dissatisfied.
next,
Some patient-based outcome measures use an explicitly derived weighing system for responses. The weights can be assigned by a panel of patients and health professionals. For example, the Nottingham Health Profile, based on preference measurements obtained from random samples of the general population, such as the Health Utilities Index. The fact that weight scored systems appear to be much more exact with their scoring suggests that they might be more precise, but this may well be deceptive.
Next.
Several studies have compared weighing and ordinal scoring systems and have not shown any significant differences in precision between these two methods of scoring. Ceiling and floor effects may influence scores of instruments. Some patient-based outcome measures do not include questions that would identify very poor levels of health. So all patients with poor health have similar scores and further deterioration will not be identified. Some, Sometimes patients with minor health problems will be scored as having excellent health, so treatment of their problems will not result in any improvement in score.
Next.
One other important factor in precision is bias. This can be reduced by general aspects of study design, such as making assessments blind to intervention. In many cases, it is not possible to keep the patient blind to which treatment arm of the trial he is in, so his judgment of outcomes may be influenced.
So this point I want to discuss because the important factor in precision is bias. Whether bias is there or not, you should be able to see because sometimes bias causes all problems. So all the assessments in the study design should be done blind to the intervention. Patient should not be knowing whether they are taking treatment or not. That is, you'll take the consent, but you'll be making them blind. Okay, and blind means they do not know what they are taking. In many cases, it is not possible to keep the patient blind because he has to be knowing what treatment is undergoing. So judgment outcomes may be influenced because of this bias. Next.
A patient-based outcome measures may therefore vary in how precisely their score relate to underlying distributions of patients' health status. Researchers need to carefully consider factors that might influence precision. The degree of precision required of a patient-based outcome measure will depend on other aspects of trial design, such as sample size and the expected differences between the arms of trial.
So this is very important. Last point is very important. Whether sample size is important and then differences between the arms of the trial is also very important. And bias is also very important for this particular precision or sensitivity. Okay, for this precision or sensitivity, very important. So what is that? Sample size and difference between the arms of the trial. Next.
Interpretability. Can results from the measure be interpreted clinically and are they relevant? The interpretability of an instrument is concerned with how meaningful are the baseline scores or a change in scores. Clinically important changes in scores can be estimated by comparison with clinical or laboratory tests in the same patient group. Representative data are available from the general population for some widely used instruments such as Health Utility Index and the SF36.
So this is called as health utilities index, health utility index and utility measures. So whether you can interpret or not, whether clinically relevant or not, you should be keeping in mind. And important changes are estimated with comparison with clinical or laboratory tests. That also should be kept in mind. Next.
The scores from the trial patients can be compared with the means and the standard deviations from the general population. A significant change in the score in the trial could be set at 1.5 standard deviations from the population mean. Normative data can be key in interpreting both state and change questionnaires, as assumptions of no treatment resulting in no change outcomes can be erroneous. For example, in a study of hearing aid intervention, those who were not given hearing aids exhibited participant acquiescence, a statistical significant increase in benefit without intervention.
So last is very important. Last point. Where interpretability, you are able to interpret whether the hearing aid is useful or not in a patient. That is one important point. Next.
Acceptability. Clearly, it is essential that the format of instrument and the questions are acceptable to patients. An instrument should not cause distress to patient or be difficult to understand. In general, shorter instruments are more acceptable to patients. The instruments to patients should make it very clear that their answers will not influence the treatment.
So acceptability is very important point, and whether acceptable to the patient or not, the instrument should not cause any distress to the patient or difficult to understand. It should be very easily acceptable. And shorter instruments are very easily acceptable. And last point is that the answers will not influence the treatment. Next.
Acceptability is also important in order to obtain high response rates to questionnaires to make results of trials easier to interpret. more generalizable, and less prone to bias due to non-response. When choosing an instrument, it is useful to know if the instrument has been used in similar setting before. Ideally, acceptability of an instrument should be directly tested at the design stage by seeking the views of patients. Subsequently, evidence of acceptability can be found in patient response rates.
You should keep in mind about that high response rate to questionnaires, easier to interpret. So response is good means easier to interpret, and you can be generalizing and less prone to bias. So acceptability is one of the important factor for that. And while choosing an instrument, you should know the settings before, and the acceptability of instrument is directly tested at a design stage for seeking the views of the patient. The evidence of acceptability can be found in patient response rates. Next.
Feasibility. The feasibility of an instrument is dependent on the time available for its completion and the staff available to help with its completion, either by intervening patients or explaining the instruments to patients. The data collected have to be entered onto the computer, and the time required and ease of entering has to be considered. The measure must be short enough to be completed or administered in the intended setting and with the types of patients and families involved in the trial. This is one of the criteria of the patient-based outcome measures that can be usually be easily judged by investigators in the research setting, and if in doubt, feasibility can be assessed by piloting the study methods.
So feasibility can be assessed by piloting the study methods. Feasible, whether the study is feasible or not, that is very important. Next.
The types of patient-based outcome measures. There are two basic types of patient-based outcome measures, generic and specific. Generic instruments assess multidimensional health profiles, overall medical condition, and personal function. Specific instruments focus on the problems found in the individual disease and disabilities and patients groups. Within each of these categories, there are different types of instruments.
So now we are discussing about the types of patient-based outcome measures. What are the types that you are trying to think? So two types are there, generic and specific. So generic is a multidimensional one, and then specific is focus on a particular disease. Next. So in this table, you are able to see generic and specific. We have already discussed. Generic is related to health profile and utility. Health utility is related to health utilities index and EQ5D, and health profile is related to sickness impact profile, Nottingham health profile, Glasgow benefit inventory. All these things are the generic things which are generally useful for most of the patients. And specifically, if you say you have a dizziness handicap inventory, so dizziness handicapped inventory (DHI), and site specifically, if you want to see SNOT-20, what is that? Sinonasal outcome test SNOT-20, and dimensional specific, you can go for McGill pain questionnaire. So specifically, if you want to say, so you have got a McGill pain questionnaire. That is also very important. So what is this patient-based outcome measures? There are two categories, that is generic and specific. Generic and specific patient-based outcome measurements. Next.
Generic instruments. Generic instruments are designed to assess a broad range of aspects of health status and the consequences of illness, and therefore to be relevant to a wide range of patient groups and conditions. The advantage of generic instruments is that they can be used for a broad range of health problems, and this enables comparisons across different groups of patients with diverse conditions. Because of their broad range of content and general applicability, such instruments have been used to assess the health of samples from the general population. Such data have been used to generate normative values across populations with which other groups of patients with specific health problems can be compared.
So generic instruments. Generic means a broad range of aspects. Next.
Since generic instruments are used more often than specific instruments, there are usually more data available about their reliability and validity. As generic questionnaires covers a broad range of aspects of health status, many items may be relevant to a particular condition. These items results in a wide range of scores that are not relevant to the condition being studied. As there are few questions relevant to a specific condition, the instrument may be insensitive to changes that might occur as a result of the treatment of that condition.
Next.
Health profile. SF36. The most commonly used health profile instrument in the medical outcome study short form 36 item health survey SF36. The SF36 is a 36 item self completed questionnaire that measures health status in 8 dimensions: physical functioning, role limitations due to physical problems, role limitations due to emotional problems, social functioning, mental health, energy and vitality, pain, and general perceptions of health. It can be completed by patients in less than 10 minutes. Responses are someone to give a score for each dimension: physical component summary and mental component summary.
Next.
It has been used in a wide variety of patient groups and conditions, including many otolaryngological conditions. Data from trial subjects can be compared with normative data for the population. Garrett identified 408 papers that included aspects of development and evaluation of the SF36 over a 10-year period. It can also be used in a reduced 12-item version that is a subset of the original SF36.
Next.
However, the large instrument gives more reliable estimates of individual levels of health and is therefore the better choice of instrument in small studies. Recently, Brazier derived from the SF36 a preference-based single index measure, the SF60, to make the instrument more useful in evaluation of cost effectiveness. This weight scoring model could potentially be applied to any SF36 dataset. However, initial validation studies demonstrated some inconsistencies, and further assessment of scoring model is required.
Next. So examples of this SF36 in ENT, as you could see, chronic rhinosinusitis, we have got Van Agthoben et al. And Lickich and Metzen. So all these are scientist names. That's it. Nothing much to remember. In this chronic otitis media has got something, and dysphonia also Mackenzie et al. Scale, and then laryngeal cancer Stewart et al. Scale, and Meniere's disease Lopez Escames et al. Scale, and rhinoplasty Klassen et al. Scale. All are examples of SF36 scales in this particular otolaryngology. Next.
World Health Organization Disability Assessment Schedule 2.2. The World Health Organization Disability Assessment Schedule 2.0 was designed to measure domain coincident with the definitions of the WHO's International Classification of Functioning, a replacement for the stigmatized labels of impairment, disability, and handicap. It is very similar to the SF36, except that its sixth domain, cognition, mobility, self-care, interaction, life activities, example, leisure and work limitations, and social participations, example, emotional and social burden, fit in the ICF framework. To date, it has only been applied to otolaryngology with regard to hearing aid, where it was found to be sensitive in intervention, but the effective size was modest compared to the hearing-specific questionnaires.
Next.
Sickness impact profile. Sickness impact profile is a general health status questionnaire comprising 136 questions answered as either yes or no. They are grouped into 12 categories: walking, body care and movement, mobility, social interaction, alertness behavior, emotional behavior, communications, sleep and rest, eating, home management, recreational activities, and work. Each item is weighed, and the scores of all answered questions are combined.
Okay. Next.
There are 12 category scores. Uh, Two summary scores: physical and psychosocial, and total score. The scores are standardized and range from 0 to 100 points, with 100 indicating the poorest function. The retest reliability and internal consistency are high, and it has good content and construct validity. It is, however, a long questionnaire and is usually administered by interview. Its acceptability and feasibility in a trial must be carefully considered.
Next.
Nottingham Health Profile. The Nottingham Health Profile is a generic, self-administered questionnaire designed to measure precise physical, social, and emotional health problems. An initial pool of statements was collected from patients at interview, and from this pool, 38 items were chosen related to 6 dimensions: physical, mobility, pain, social isolation, emotional reaction, energy, and sleep. The scores can be compared with the average scores in a population matched for gender and age.
Next.
Glasgow benefit inventory. As other generic instruments are often insensitive to the non-acute disorders generally seen in an oral clinic, the Glasgow benefit inventory was developed for use in patients with otolaryngological conditions. The GBI is a post-intervention questionnaire that assesses the effects of intervention on the health status of patients rather than the actual health status. The GBI has 18 items in three domains: psychological, social, and physical well-being.
Next. Next.
Rather than attempt to assess the difference between before and after treatment measures, it asks directly about the change in health status resulting from treatment. It is likely, therefore, to be more sensitive to such change than two separate instruments before and after intervention. In addition, compliance will be significantly higher because patients are only required to complete the one questionnaire.
Next.
The response to each question is based on 5-point like scale. For example, since your operation intervention uh, have found have you found it easier or harder to deal with company? Uh, in each question, the responses are scored using a weight scale from a population samples to give a score between -100 and +100. The GBI has been used to assess the benefit experienced by the patients following various treatments. Henry et al. Wrote a comprehensive review of the use of GBI.
Next. Next. So this is all the things that is done by different people. Examples of this GBI. So this Glasgow information, this one is based on all these different types of treatment. They have placed this charting. Next.
Utility measures. Multi-attribute utility measures assess a broad range of aspects of health status, like other generic instruments, but have a particular form of numerical weighing or valuation of health states. Utility measures have been developed from economic and decision theory in order to provide an estimate of an individual patient's overall preferences for different health states. They are scored as a single number between 1 full health and 0 death.
Next. Next.
Weight scoring method is based on the preference measurements obtained from samples of general population. They are asked to value different aspects of health as defined by the instruments using one of the number of valuation techniques, most commonly standard gamble, time trade-off, and visual analog scales. Utility scores reflect the health status and value of that health status to the patient.
Next.
As utility measures are scored as a single value, they do not define individual dimensions of health that contribute to the individual's overall sense of well-being. They are relatively insensitive to small but relevant changes in health and are therefore more suited to studies of larger populations. There are several health utility measures that have been widely used. Brazier carried out an extensive review of this and recommended the Health Utility Index and the Euro Quality of Life as the instruments of choice.
Next.
Health Utilities Index. Health Utilities Index evolved from the studies in the neonatal intensive care. A second version was developed to assess outcomes in long-term survivals of childhood cancer, but is suitable for use in wider range of children. How it is claimed to be the generic instrument, its content is explicitly aimed at children with questions specifically aimed to developmental age.
Next.
The HUI2 was revised to make it more relevant to an adult population. The HUI3 assesses 8 aspects of health status: vision, hearing, speech, ambulation, dexterity, emotion, cognition, self-care, and pain. It has 15 questions with 4 to 6 available responses for each and is easy for patients to complete. The HUI-3 has been used in wide variety of clinical studies and has been shown to be reliable and responsive.
Next.
It is one of few generic patient-based outcome measures that specifically assesses hearing and speech and is therefore potentially useful in many areas of otolaryngology. Normative data have been collected from larger population and from these data weighing score scales have been devised. It has been used in a cost utility study of cochlear implants and in the UK cochlear implant study.
Next.
EQ5D. The EQ5D is a self-completed questionnaire with 5 dimensions: mobility, self-care, usual activities, pain or discomfort, and anxiety or depression. It is easy to complete and very acceptable to patients. Responses can be scored using a weight scale from a large general population sample.
Next.
It is very brief with only 5 questions and 3 levels of responses for each. It was compared with the Euro quality of life and the SF36 in a survey of 1980 adults, and the Eurocall was found to be less sensitive. However, it was originally intended to complement other forms of health-related quality of life measures. It has been widely used, and its test reliability is good.
Next.
Specific instruments.
So I think